So I'm going to go ahead and do introductions in order to get started for today. So we're stabilizing in our attendee count, so that's great. So welcome to the second day of pre-licensing training. We're so glad you're here with us. This training is for people who intend to become certified application counselors or navigators, as well as agents and brokers. We welcome anyone who is interested in the content, and we're glad you're with us this morning. I'm Shannon Drake Burr, covering Wisconsin's Workforce and Affiliates Liaison. And today my colleague, Adam Van Spankeren, covering Wisconsin's Navigator Program Manager, is joining us as co-host. So maybe Adam can wave hello. Thanks, Adam. I want to let you all know that pre-licensing sessions will continue today as well as tomorrow, and remind you that regular conference sessions are September 28th through the 30th and October 3rd and 4th. And all of that occurs from 9 to noon each day. In order to obtain all 16 pre-licensing credit hours, which are required by Wisconsin's Office of the Commissioner of Insurance in order to become a certified application counselor or a navigator, you will need to attend all pre-licensing sessions, and all regular conference sessions. So in today's first session, we will learn about elderly, blind, and disabled Medicaid, often called EBD Medicaid. We'll learn about eligibility criteria, full benefit programs versus limited benefit programs, and we'll be introduced to many of EBD Medicaid's sub-programs. In today's second session, which is called Health Insurance 101, which will be presented by Shelly Knorr and Barbara Belling from Wisconsin's Office of the Commissioner of Insurance, we'll learn about general principles of insurance, the powers and duties of the Office of the Commissioner of Insurance, and about the complaint process at the Office of the Commissioner of Insurance. I want to remind you all, if you have questions, to please put them in the Q&A, which most likely appears at the bottom of your screen. We will be monitoring questions and will take strategic breaks throughout the sessions to address them. Also, there will be polling questions throughout the session. The polling questions are interactive and will appear on your screen. Please make certain to respond to the polling questions. It is part of obtaining your pre-licensing credit hours. So now it is with great pleasure that I'd like to reintroduce Nikki Biddick, today's presenter. Nikki is a policy analyst at the Department of Health Services. She is in the outreach and enrollment section, and her work focuses on elderly, blind, and disabled and long-term care customers, and she has nearly 24 years of experience in that field. Masiel Gomez will be supporting Nikki throughout the presentation, and Masiel is an enrollment and outreach coordinator with the Department of Health Services, and she'll be providing support throughout the presentation. So now it is with great pleasure that I pass the presentation baton to Nikki for her presentation on elderly, blind, and disabled Medicaid eligibility rules.
Thank you, Shannon. Good morning, everybody. Again, I'm Nikki Biddick. I'm here to talk to you about elderly, blind, or disabled, or EBD Medicaid today. I am going to go ahead and bring that slide deck up. I just want to make sure that it's being seen before I continue. Good. Awesome. Thank you. I did present both the Applying for Wisconsin's Healthcare Programs and the Badger Care Plus eligibility rules session yesterday. If you were with us for one of those or both of those sessions, hopefully you're not getting too sick of me yet, but good news if you are, this is the last session I'll be presenting. So our session will end at 10:15 this morning, and then the next session will start at 10:30. And as Shannon said, I'll be checking in periodically throughout the presentation for questions that you can type in that Q&A box. I do just want to preface today's presentation by saying EBD is a lot. I know that. So depending on the number of questions that come up, I may have to move us along to be sure that we get through all the content. But just like yesterday, if we have any questions that we're unable to answer or don't have time to answer, we'll be sure to keep track of those and get those answers back to Shannon so she can follow up with you all later. All right. Let's go ahead and get started. The agenda for today includes going over the purpose of this training, an overview of Medicaid, including the non-financial and financial rules, as well as the sub-programs of Medicaid, and then finally some resources for you as well. I know I mentioned this a couple of times yesterday, but I want to again provide you with some information about the COVID-19 temporary rules that are currently in place. Temporary changes have been made to Medicaid policy during the federal public health emergency, including maintenance of eligibility for existing members, postponements of renewals, suspension of premiums, suspension of the work requirement for MAP, and addition of the elderly, blind, and disabled population to presumptive eligibility. And just to note, that's presumptive eligibility, not presumptive disability, which we will talk about briefly later. So the information provided in the training today does not include those temporary rules. For example, you're going to hear me talk about a work requirement when we get to the MAP information. Due to the temporary rules in place, there is no work requirement for MAP at this time. But again, we want to provide you with the rules as they normally are and will be again, as far as we know, once the COVID-19 federal public health emergency ends. The purpose of this training is to provide navigators, certified application counselors, partners, agents, and brokers with an overview of the eligibility rules for EBD Medicaid programs. As a reminder, we discussed applying for Wisconsin's healthcare programs and Badger Care Plus yesterday, so we won't be talking about how to apply for EBD Medicaid since we did already discuss that yesterday. Medicaid for the elderly, blind, or disabled, or EBD Medicaid, covers adults age 65 and older and individuals who have been determined blind or disabled by the Disability Determination Bureau, also known as the DDB. Now, many people will often confuse Medicaid with Medicare. Medicaid is a joint federal and state program that provides high-quality healthcare coverage, long-term care, and other services to over 1 million Wisconsin residents, and is the topic of our conversation today. Medicare is a health insurance program administered by the federal government and divided into 4 parts. Part A, which provides coverage for hospitalization and skilled nursing facilities. Part B, which covers such things as doctor visits. Part C, Medicare Advantage, which is a supplemental coverage sold by private companies. You may have also heard of Part C being referred to as Medigap. And Part D, which provides prescription drug coverage. Again, Medicaid and Medicare, 2 different programs. We're discussing Medicaid today. So let's first look at an overview of EBD Medicaid. As I mentioned yesterday, please keep in mind that this training provides an overview of the eligibility factors that will be considered for EBD Medicaid. It's not intended as a training on how to determine eligibility. Only income maintenance or IM agencies can determine eligibility for most programs. More information about specific programs and policies can be found in the Medicaid Eligibility Handbook, or MEH, which you can find by following the first link shown on this slide. And the policies described in this training are subject to change. Updates are available a couple of ways. The second link shown on this slide is a biweekly stakeholder call series hosted by DHS to provide information about eligibility policy updates and rule changes affecting Wisconsin programs such as food share and Medicaid. And then the last link shown on this slide, which was also given yesterday, takes you to a site where you can sign up to receive email updates regarding DHS programs and services. Full benefit EBD Medicaid includes many different programs. We're going to start by giving you some basic information about those programs and then get into more detailed information about each one in a bit. Supplemental Security Income, or SSI Medicaid, is for people who are getting federal Supplemental Security Income, or SSI, payments. Individuals receiving SSI are automatically eligible for Medicaid, and they don't need to apply for Medicaid through the IM agency. SSI-related Medicaid is the basic EBD Medicaid program for people who are age 65 or older, blind or disabled, but who are not getting SSI. A Medicaid deductible allows people who are above the income limit for SSI-related Medicaid to become eligible for Medicaid after they have met a deductible. Special status Medicaid is for people who once received SSI, but no longer do, and with a special disregard, still meet the criteria for Wisconsin's SSI-related Medicaid. Medicaid Purchase Plan, or MAP, is for individuals with a disability who are working or want to work. The Katie Beckett program is for children with disabilities who require an institutional level of care. Well Woman Medicaid is for women under age 65 who need treatment for breast or cervical cancer or certain precancerous conditions. Institutional Medicaid is for elderly, blind, or disabled people who are living in a nursing home, hospital, or other institution. And home and community waivers help elderly, blind, or disabled people live in their own homes or in the community rather than in an institution. There are also some limited benefit Medicaid programs. Individuals eligible for these programs have limited coverage, not full benefit coverage. Emergency services covers services needed for the treatment of an emergency medical condition if the individual meets all program rules except for qualifying immigration status. Senior care is a prescription drug assistance for individuals who are age 65 and older. The Wisconsin Well Woman Program, or WWWP, is a limited benefit Medicaid program. It provides women ages 45 through 64, with some limited exceptions to the age group, specific preventative health screening services related to breast and cervical cancers. The Medicare savings programs help individuals enrolled in Medicare pay their Medicare premiums, deductibles, copays, and/or coinsurance. So again, Medicare is that health insurance program administered by the federal government, has parts A, B, C, and D. It's not Medicaid, but the Medicare savings programs are Medicaid programs that can help people pay some of their Medicare costs. And we will talk about those in more detail in a bit. So let's take a look at some of the basic non-financial and financial rules for EBD Medicaid. Individuals must be elderly, which is 65 or older for Medicaid, or have been determined blind or disabled by the Disability Determination Bureau, or DDB, to be eligible for EBD Medicaid. As a note, some individuals may be eligible for what's called a presumptive disability determination. A presumptive disability determination is a method for temporarily determining a disability for an individual, while a formal disability determination is being processed by the DDB. We're not going to be diving into presumptive disability information this morning, but I did want to mention it because people often confuse presumptive disability with presumptive eligibility when they're two totally different things. So, and remember, we did discuss presumptive eligibility yesterday. That was that express temporary enrollment into Badger Care Plus or family planning only services based on the presumption of eligibility for those programs. Now, I did want to give you a couple of references. Presumptive disability information can be found in Medicaid Eligibility Handbook, Chapter 5.9, while presumptive eligibility information can be found in Badger Care Plus Handbook, Chapter 40.2. Okay, so individuals must be elderly, blind, or disabled to be eligible for EBD Medicaid. They must also be a Wisconsin resident, which means they must be physically present in the state with an intent to continue residing in Wisconsin. And they must also be a citizen or qualifying immigrant. Additionally, individuals must provide a Social Security number with a few exceptions. They must supply the required information and verification within the required time frame. And they must pay premiums or cost sharing if they are required by the specific program that they have eligibility for. Most EBD Medicaid subprograms have an income limit and an asset limit, but these do vary by program. Some income limits are fixed amounts, while others are based on the federal poverty level, or FPL. FPL is the federally determined income amount that's scaled based on household size and is usually adjusted every year. Current FPL amounts for EBD Medicaid can be found at the link shown on this slide. Now, most subprograms count the income and assets of the member and his or her spouse. There are some exceptions that apply to children with disabilities, though. Children are not subject to an asset test, and in some cases, parents' income is not counted or is only partially counted for children with disabilities. Countable income for EBD Medicaid includes, but isn't limited to, gross earned income, self-employment earnings, Social Security income, retirement benefits, unemployment insurance, income from trusts, interest and dividend income, child support, and alimony. Income types and rules are outlined in the Medicaid Eligibility Handbook, or MEH, in Chapter 15. Countable assets for EBD Medicaid include, but aren't limited to, cash, checking, and savings accounts, stocks, bonds, and certificates of deposits, or CDs, non-home real property, some vehicles, some trusts, some life insurance policies, some burial assets, some annuities, some loans, and some reverse mortgages. Asset types and rules are outlined in MEH Chapter 16. You notice there was a lot of sums there, and that's because depending on how things are set up, they are sometimes not counted assets. So now there are also some allowable deductions for EBD Medicaid, and those do vary by subprogram. However, all EBD Medicaid programs allow a $20 standard deduction, as well as a $65.50 earned income deduction. The $65.50 earned income deduction is calculated by removing $65 from the household's earned income, then deducting half of what's left. So an example of that would be if someone has $1,065 per month in earned income, $65 would be deducted, leaving $1,000. Half of $1,000 is $500, so the total deduction would be $565, and the countable earned income would be $500. There are subprogram specific deductions as well. So depending on the subprogram being determined, some examples of those subprogram specific deductions include support payments, court-ordered attorney or guardian fees, impairment-related work expenses, and medical and remedial expenses. And we're going to take a closer look at some of these subprogram specific deductions when we take a closer look at those programs in just a bit. That brings us to our first poll question. So our first poll question is, which of the following individuals may be non-financially ineligible for EBD Medicaid based on just the information given? A, Janice, a 44-year-old who has been determined disabled by DDB. B, Edgar, age 68. C, Penelope, age 70, living in her home in Minnesota. Or D, Ricardo, a 24-year-old who has been determined blind by the DDB. Again, which of the following individuals may be non-financially ineligible for EBD Medicaid based on the information given? We'll give you some time to answer those. Looks like we're currently at about 60% of people answering, so hopefully we can get to 100% here. We'll do probably about 30 more seconds. All right, hopefully you've all been able to submit an answer. It looks like most of you have submitted the answer as C, Penelope, age 70, living in her home in Minnesota. Great job, individuals. That is the correct answer. C, individuals must be physically present in the state of Wisconsin to be eligible for EBD Medicaid. Since Penelope is currently living in Minnesota, she would not be eligible. Any questions before we dive into more detail about the Medicaid programs? I just want to give a minute here to see if there are any questions. Do you have any questions about why C was the correct answer? Doesn't look like we're getting any questions popping up, so feel free to ask them though, and we can always get back to them. So, all right. Now that we've talked about the basic non-financial rules for EBD Medicaid, let's take a closer look at each of the sub-programs in more detail. First, let's talk about SSI Medicaid. Again, the federal SSI program provides cash benefits to people who have little or no income or assets, who are 65 or older, blind, or disabled. SSI has income and asset limits similar to those used for EBD Medicaid. In Wisconsin, if someone qualifies for the federal SSI payment, they will also receive the state payment. Also, if someone is getting SSI payments, remember they automatically qualify for SSI Medicaid. This means they don't have to apply for Medicaid separately, and their eligibility for Medicaid is not determined by the IM agency. And SSI Medicaid is a full benefit Medicaid program. Now let's talk about SSI related Medicaid. This is different than SSI Medicaid, which is the Medicaid someone gets if they're receiving SSI payments automatically, although the coverage for both of these programs is the same since they're both full benefit Medicaid programs. SSI related Medicaid is the basic EBD Medicaid program for people who are elderly or blind or disabled as determined by DDB, but who are not receiving SSI. Eligibility for this program is determined by IM agencies. The income limit for this program is 100% of the FPL. So for one person, that amount is currently $1,132.50. And for a couple, 100% of the FPL is currently $1,525.83. I want to mention that SSI-related Medicaid is outlined in the Medicaid Eligibility Handbook, or MEH, Chapter 24. SSI-related Medicaid also has an asset limit. For a single individual, countable assets must be below $2,000, and for a married couple, countable assets must be below $3,000. Now, if someone is over the income limit for SSI-related Medicaid, they can become eligible for SSI-related Medicaid by meeting a deductible. Deductibles are often also referred to as spend downs. Deductible rules are also outlined in MEH Chapter 24. Medicaid deductibles are calculated for a 6-month period by removing 100% of the FPL from the total countable monthly income and adding the 6 remainders together. And again, 100% of the FPL for one person is currently $1,132.50. So for example, If a single person's countable monthly net income was $1,232.50 for each month of their 6-month deductible period, and the income limit didn't change during any of those months, they would be $100 over the income limit for each month, and their total deductible amount would be $600. Now, there are several ways to meet a deductible. Individuals can submit unpaid and recently paid medical bills to meet a deductible. They can choose to prepay the deductible in order to obtain coverage, or they can have a combination of unpaid or recently paid medical bills and prepayment. Information about how to meet a deductible is outlined in MEH Chapter 24.7. Now, once a deductible is met, the individual is eligible for full benefit Medicaid coverage, and then Medicaid pays for covered services from the point the deductible is met until the end of the 6-month deductible period, at which time a renewal would be due. So here's an example. Bobby is a single 68-year-old with total countable income of $1,500 per month. She applies for healthcare in July and is over the income limit for SSI-related Medicaid, so the IM agency calculates a deductible period for her from July to December, the period of 6 months. Since Bobby's income was the same for all 6 months, and since the income limit also remained the same for all 6 months, the total amount she is over the income limit for each month won't change, and it is $367.50 for each month. So the total amount of her 6-month deductible is $2,205. So this is the amount she must meet before she can be eligible for Medicaid. On July 6th, Bobby has outpatient surgery and has unpaid medical bills that she does not anticipate any other entity to cover. Those unpaid medical bills total $3,500 from the procedure, and she submits proof of those bills to the IM agency to meet the deductible. Now, by meeting the deductible, she becomes eligible for Medicaid from July 6th, the date she incurred the bill, until the end of December, the end of her deductible period. Now, she would be responsible for the portion of the bill used to meet the deductible. So she's still going to owe the hospital that $2,205 because that was the amount of her deductible. But the remaining amount of $1,295 can be billed to Medicaid, and Medicaid should pay as long as the bill was for covered or services that are covered by Medicaid, also known as covered services. And covered services are outlined in MEH 21.4. And that brings us to our second poll question. Which of the following is not a true statement for SSI-related EBD Medicaid? A, the asset limit for a single person is $2,000 per month. B, SSI-related Medicaid deductibles are set up for a period of 6 months. C, the income limit for SSI-related Medicaid is 100% of the federal poverty level. Or D, the only way to meet a deductible is to prepay the amount. Again, which of the following is not a true statement for SSI-related EBD Medicaid? We're going to go ahead and give you some time to answer that. We have one person saying they can't see the poll, so I'm unsure. Just wanted to mention that. Looks like we've almost got 100%, so maybe give it another 20 seconds. All right. And it looks like most of you did choose D, which is the correct answer. Prepaying a deductible is not the only way to meet a deductible. Individuals can also submit unpaid or recently paid medical bills to help meet a deductible, or have a combination of bills and prepayment. So before we move on, I just want to make sure I ask if there are any questions about EBD related Medicaid or deductibles before we move on to MAP. I'm going to give you a little bit of time. If you have any questions about EBD Medicaid or deductibles before we move on to MAP. No?
Looks like you're clear.
All right. All right, let's go ahead and talk about Medicaid Purchase Plan or MAP. MAP is a Medicaid subprogram. It's a full benefit Medicaid program, and it is determined by IM agencies. MAP is for individuals with a disability who are either working or enrolled in a health and employment counseling program, also known as HEC. The program has higher income and asset limits to allow members to get healthcare coverage while they are employed. MAP information, including information about the Health and Employment Counseling Program or HEC, can be found in MEH Chapter 26. Now, as a reminder, the work requirement for MAP is currently being waived due to the temporary COVID-19 rules. The income limit for MAP is 250% of the FPL based on a household that includes the member's spouse, and the member's minor dependent children. Stepchildren are not included in the household size. For example, if Fred was applying for MAP for himself only, and his household included himself, his spouse's minor child with someone else, and a minor child that Fred and his spouse have in common, Fred would be a household size of 3, and his income limit would be $4,797.93 a month. The member and their spouse's net income is compared to the income limit for the household size. So for Fred, his household size was 3. So his and his spouse's income would be compared to that income limit for a household size of 3. Now, MAP does allow that $20 standard deduction, and it also allows a $65.50 earned income deduction that we talked about earlier. It also allows an impairment-related work expense deduction. You might also hear them called IRWIs, a special exempt income deduction, and a medical and remedial expense deduction if the applicant and spouse have medical remedial expenses that total more than $500. Now, premiums for MAP are charged based on the member's income only. If the member's gross income exceeds 100% of the FPL for a group of 1, and again, currently that amount is $1,132.50, then a premium will be charged. However, as a reminder, premiums are currently being waived due to the temporary COVID-19 rules we discussed earlier. And then finally, the asset limit for MAP is $15,000, and only the member's assets are counted. So household size includes the member, his or her spouse, and minor children of the member only. Net income, which is the income used to compare with the household size, includes the member and his or her spouse's income with allowable deductions. Premiums are charged based on only the member's income and are currently being waived, and only the member's assets are counted for MAP. Questions about MAP before we move on? Would a joint asset count? Yes, it would count. How much of the asset will count is dependent on who the joint asset is owned with and whether or not the joint owners are both elderly, blind, or disabled. But a joint asset will count. If the person that's applying has a joint asset with someone, at least a portion of it will count for sure. Any other questions?
Wait, we got another one.
Yep, MAP enrollee can only be EBD. That is correct.
That's
Individuals, yep, have to be elderly, blind, or disabled. All right, we'll go ahead and move on then. Long-term care Medicaid programs include institutional Medicaid as well as home and community waiver programs such as family care partnership, include Respect I Self-Direct, also known as IRIS, program of all-inclusive care for the elderly, also known as PACE, which is available in Milwaukee and Waukesha counties only, and Children's Long-Term Support Program, also known as CLTS. Institutional Medicaid is Medicaid for elderly, blind, or disabled individuals who are living in a nursing home, hospital, or other medical institution. Eligibility for this program is determined by IM agencies. The individual must have either resided in a medical institution for 30 or more consecutive days or be likely to reside in a medical institution for 30 or more consecutive days as attested to by the medical institution in order to be eligible for institutional Medicaid. Medical institutions include, but are not limited to, hospitals, skilled nursing facilities, intermediate care facilities, and in some cases, institutions for mental disease. When someone applies for health care and indicates they're in an institution or need institutional care, that's considered an application for institutional Medicaid. Financial rules for institutional Medicaid include eligibility and cost sharing are determined based on income, assets, the cost of care for the medical institution, and other qualifying expenses. For a single individual, the monthly income limit is $2,523. They may also qualify if their income is less than their cost of care plus other expenses. For a single individual, the asset limit is $2,000. Some income and assets may be allocated to the applicant's spouse and/or minor children. And divestment penalties may apply to people who sell or give away income or assets for less than their fair market value. Now, divestment penalties are periods of ineligibility for long-term care services based on the amount divested or given away. A member would remain eligible for card services only while in a divestment penalty period, and card services are outlined in MEH Chapter 21.4.1.1. Basically, if someone's in a divestment penalty period, they'll still have their regular Medicaid eligibility, like if you were eligible for MAP or EBD Medicaid, but they won't have any of their long-term care services covered if they're in a divestment penalty period. Questions about institutional Medicaid before we move on to home and community waivers? No? Again, if you do, pop them in there and we'll try and get to them before the end of our session. So, or we'll get an answer back to you later if we can't. All right. Home and community waivers programs help people live in their own homes or in the community rather than an institution. Individuals must be eligible for a full benefit Medicaid program or long-term care waiver Medicaid, which is also a full benefit program, to be enrolled into a home and community waiver program. Individuals must meet a certain level of care called a nursing home level of care, as determined by the Aging and Disability Resource Center, or ADRC. Individuals must contact the ADRC for enrollment counseling to have their level of care determined. The ADRC will help to identify the most appropriate home and community waiver program for the individual. If the individual is already eligible for full benefit Medicaid, the ADRC can go ahead and enroll that individual in the appropriate home and community waiver program. If the individual is not already eligible for full benefit Medicaid program, then the individual must also submit a Medicaid application to the IM agencies. To find an ADRC in your area, you can follow the link that's shown on this slide. Long-term care waiver Medicaid is a specific form of full benefit Medicaid used to enroll individuals in a home and community waiver program when they're not eligible for any other form of full benefit Medicaid. Individuals must be elderly, blind, or disabled to be eligible for long-term care waiver Medicaid. Remember, on the last slide, we said that individuals already eligible for full benefit Medicaid could be enrolled in a home and community waiver program by the ADRC, but if they weren't already eligible, a Medicaid application would need to be submitted to the IM agency. The IM agency then determines eligibility for Medicaid. They check for all full benefit Medicaid programs first. And then if the individual is not eligible for any of those other full benefit Medicaid programs, they will check for long-term care waiver Medicaid as well. The financial rules for long-term care waiver Medicaid are very similar to the rules for institutional Medicaid that we just talked about, including that some income or assets may be allocated to the applicant's spouse and/or minor children, and the fact that divestment penalties may be applied to people who sell or give away income or assets for less than their fair market value. And that brings us to our next two poll questions. We have one right after another. So poll question number 3 is, when determining eligibility for Medicaid Purchase Plan or MAP, which of the following is not true? MAP has higher income and asset limits than SSI-related EBD Medicaid. B, assets of everyone in the home are counted for MAP eligibility. C, when determining if a MAP premium will be charged, only the member's income is counted. And D, when determining the MAP household size, stepchildren are not included. Which of the following statements is not true for MAP? And we'll give you some time to answer that. Looks like we've got about half of people have submitted an answer. Maybe give it another 15 or 20 seconds. All right, looks like a majority of you chose B, which is the correct answer. Great job. Only the MAP individual's assets are counted for MAP, not the assets of everyone in the home. Great job. And that's going to roll us right into our next poll question. Poll question 4, which of the following is not true for institutional Medicaid? A, Medical institutions include, but are not limited to, hospitals, skilled nursing facilities, and intermediate care facilities. B, for a single individual, the asset limit is $2,000. C, some income and assets may be allocated to an applicant's spouse and or their minor children. Or D, to be considered institutionalized, the individual must have resided or be expected to reside in a medical institution for 60 or more consecutive days. Which of those statements is not true for institutional Medicaid? Looks like we've got about half of you responding so far. Give it about 30 more seconds. All right, let's see what our results are. All right, looks like a majority of you did choose D, which is the correct answer. Great job. To be considered institutionalized, the individual must have resided or be expected to reside in a medical institution for 30 days or 30 or more consecutive days, not 60 days. So I want to take some time to pause, and I just want to allow you to enter some questions if you have any about long-term care waiver Medicaid or home and community waivers before we move on. Not seeing any questions pop in. So again, if you do think of any, please feel free to put them in that Q&A and we will get to them. All right, now let's talk about those. Oh, can you give an example of help that is provided with home and community waivers? Sure. One of those things might be the person that's eligible for the home and community waivers might need someone to come in and help them with some daily living, such as bathing, helping them get their medications. That would be just one example of the many things that are available under the home and community waivers. All right. Moving on to Medicare savings programs, we're going to talk about those in a little bit more detail. As a reminder, Medicare is not Medicaid. Medicare is that health insurance program run by the federal government, has 4 parts, A, B, C, and D, and IM agencies don't determine eligibility for Medicare parts A, B, C, and D. Medicare savings programs are Medicaid programs, but they are limited benefit Medicaid programs, not full benefit Medicaid programs that help individuals who are enrolled in Medicare pay their Medicare premiums, and in some cases, their Medicare deductibles, co-pays, and or co-insurance. IM agencies do determine eligibility for Medicare savings programs. Now, you might hear those programs referred to simply as MSP, Medicare Savings Programs. Sometimes you might hear them referred to as Medicare Premium Assistance or MPA, Or for those of us that really want to reveal how old we are, you might hear them referred to as buy-in as well. All of those things mean the same thing. It's just that what they've been called over the years has been changed. So Medicare savings programs, MSPs, MPAs, or buy-in, all the same thing. There are 4 types of Medicare savings programs. The first is qualified Medicare beneficiary, also known as QMB or QIMB. To be eligible for QMB, the individual must be entitled to Medicare Part A. The income limit is 100% of the FPL for a group size of 1 or 2. And the asset limit is $8,400 for a single individual and $12,600 for a married couple. If someone is eligible for QMB, QMB Medicaid pays their Medicare Part A and Part B premiums, although most people don't have a premium for Part A, as well as their Medicare deductibles, copays, and coinsurance. Also, QMB is the only Medicare savings program where a member will get a forward health card if they're eligible to use when paying for those Medicare deductibles, copays, and coinsurance. Now, this can sometimes confuse members. They think because they have a forward health card, they must be eligible for full benefit Medicaid, but that's not true if they only have QMB eligibility. If they're only eligible for QMB, their forward health card is only going to pay for those Medicare deductibles, copays, and coinsurance. Also, just want to let you know that being entitled to Medicare Part A is outlined in Medicaid Eligibility Handbook, Chapter 32.2.2. Someone is entitled to Part A if he or she does not have to pay a premium for Medicare Part A and is enrolled in Medicare Part A as of the QMB determination. So, for example, Mrs. Smith applies for QMB benefits August 15th. She has a Medicare card with a Part A begin date of June 1st. Since Medicare will pay for Part A services as of June 1st, she's entitled to Part A at the time of the QMB determination. And he or she must pay a monthly premium to receive Medicare Part A and fits one of the following descriptions. He or she is a Medicaid member and has been enrolled in Medicare sometime in the past. In this case, the state will attempt to enroll him or her in Medicare Part A. QMB eligibility can't begin prior to the Part A begin date. So, for example, Eleanor's Part A lapsed because she didn't work enough quarters for free enrollment and she could no longer afford premiums. When she becomes eligible for Medicaid, the state will begin paying her Medicare premiums. And then the last one is he or she is a Medicaid member or QMB or SLIMB applicant and has never been enrolled in Medicare Part A. In this case, he or she must apply at the local SSA office for Part A Medicare eligibility. He or she will receive a receipt which entitles them to enroll in Part A on the condition that they're found eligible for QMB or SLIMB. The receipt from SSA will have a Part A begin date on it. QMB or SLIMB eligibility cannot begin prior to the Part A begin date. So an example of that is Pearl was never enrolled in the federal Medicare system. She applies for QMB. Before she can become QMB eligible, she must obtain a receipt for conditional eligibility for her Part A Medicare. She goes to the SSA office during the January through March enrollment period and is conditionally determined eligible for Part A effective July 1st. She applies for QMB at the IM agency on May 1st. She becomes QMB eligible as of July 1st. So being entitled to Medicare is kind of complicated. And again, you can look that up in Medicaid Eligibility Handbook, Chapter 32.2.2. All right, some Medicaid members are also automatically eligible for QMB. People eligible to receive SSI are automatically eligible for QMB. So people receiving SSI, remember, are automatically eligible for Medicaid, so they don't need to submit an application to IM for Medicaid. And they're automatically eligible for QMB, so they don't need to submit an application to IM for Medicare savings programs either. Also, some Medicaid members who once received SSI but no longer do are automatically eligible for QMB, including 503 assistance groups and disabled adult child or DAC assistance groups. Both of those are special status Medicaid, and you can find out more about them in Medicaid Eligibility Handbook, Chapter 25.1 and 25.2. The next Medicare Savings Program is Specified Low Income Medicare Beneficiary, also known as SLIMB. In order to be eligible for SLIMB, the individual must be entitled to Medicare Part A. The income limit is 120% of the FPL for a group size of 1 or 2. The asset limit is $8,400 for a single individual and $12,600 for a married couple. If someone is eligible for SLIMB, SLIMB Medicaid will pay their Part B premiums only. So they don't get Part A premium paid for if they have a Part A premium, and they don't get those Medicare copays and deductibles paid for either. It will only pay their Part B premium. The next Medicare Savings Program is Specified Low Income Medicare Beneficiary Plus, also known as SLIMB Plus. Now, in order to be eligible for SLIMB Plus, again, the individual must be entitled to Medicare Part A. The income limit is 135% of the FPL for a group size of 1 or 2. The asset limit is $8,400 for a single individual and $12,600 for a married couple. And the individual may not be enrolled in a Medicaid program, full or limited benefit. So someone eligible for SLIMB Plus the SLIMB Plus Medicaid will pay their Part B premiums, just like SLIMB. The difference between SLIMB and SLIMB Plus is that SLIMB Plus has a higher income limit, and individuals eligible for any other form of Medicaid can't get SLIMB Plus. So they would have to choose one or the other if they're eligible for both. So someone eligible for SLIMB Plus and MAP, they can't have both. They would have to choose between the two. And then the final Medicare Savings Program is Qualified Disabled and Working Individual, also known as QDWI or QDWI. In order to be eligible for QDWI, the individual must be under age 65 and disabled. The individual must have lost premium-free Medicare Part A as a result of returning to work. The member cannot be eligible for any other Medicaid. The income limit is 200% of the FPL for a group of 1 or 2. The asset limit is $4,000 for a single individual and $6,000 for a married couple. And if someone is eligible for QDWI Medicaid pays their Medicare Part A premium only. Questions about the Medicare savings programs before we move on? I just want to give you a moment to do that. No? Okay. So let's talk about some other sub-programs. EBD Medicaid Emergency Services is a limited benefit Medicaid program that covers services needed for the treatment of an emergency medical condition when someone meets all EBD Medicaid program rules except qualifying immigration status and having or applying for a Social Security number. So this means that an individual must be either determined blind or disabled by the DDB or be eligible for presumptive disability, which we talked about earlier, to be non-financially eligible for EBD Medicaid emergency services. Now, as we discussed yesterday, emergency services is not available to childless adults ages 19 through 64 who are not living with and caring for a child under age 19, children with higher incomes, or women enrolled in the Badger Care Plus prenatal program. While emergency service applications are processed by IM agencies, it's not the responsibility of the IM agency to determine if the applicant's condition is or was an emergency condition and reimbursable under EBD Medicaid emergency services. It is the IM agency's responsibility to manually determine if the non-qualifying immigrant meets all eligibility requirements during the dates of service, and then certify them if he or she is eligible for emergency services. Medical providers who have treated a non-qualifying immigrant for emergency services may complete the Certificate of Emergency for Non-U.S. Citizenship form, that's Form F01162, to verify that the services provided were to treat an emergency medical condition, and the patient can then provide that to the local IM agency when applying for assistance, although the form is not required. Additionally, a provider's certification of emergency by completing the F01162 does not guarantee reimbursement. When the medical provider submits claims for emergency medical services to the fiscal agent determines if a condition is an emergency medical condition covered by emergency services. The fiscal agent is the state. That's Medicaid. So just to let you know. More information about emergency services can be found at the link shown on this slide. And then I did want to open it up for questions about emergency services before we move on. Might be helpful to explain what constitutes an emergency. That's not something I can, it really depends on what the emergency is. Let me just check, let me bring up the Medicaid eligibility handbook. I don't know that it even says in there because the IM worker is not responsible for determining if it's an emergency or not. So I can check the handbook. Just give me 1 second. And it is outlined, I think, in 34.1. Sorry, I'm having to move around some of the other things on my screen here in order to be able to see it.
Looks like Mike put it in the question and answers.
Did he? Okay. All right. Then I don't need to continue looking up. All right. Any other questions about emergency services before we move on? All right. The Katie Beckett program is a full benefit Medicaid program for children with disabilities who are living at home and require an institutional level of care. Applications for the Katie Beckett program are processed by DHS, the state, not by the IM agency. More information about Katie Beckett can be found at the link shown on this slide. The Wisconsin Well Woman Program, or WWWP, is a limited benefit Medicaid program. It provides specific preventative health screening services related to breast and cervical cancers, and individuals can apply for the Wisconsin Well Woman Program through their county or tribal well woman coordinating agency. And you can find more information about the Wisconsin Well Woman Program at the link shown on this slide. Wisconsin Well Woman Medicaid, or WWWMA, is a full benefit Medicaid program for women under age 65 who need treatment for breast or cervical cancer or certain precancerous conditions. So often women may be enrolled in the Wisconsin Well Woman Program, which provides those preventative screenings, remember? And then if breast or cervical or other precancerous conditions are found, they may then enroll in Wisconsin Well Woman Medicaid, which is that full benefit Medicaid for treatment. Eligibility for Wisconsin Well Woman Medicaid is based on enrollment in the Wisconsin Well Woman Program, WWWP, or Family Planning Only Services, FPOS. So no separate income or asset test applies other than those. Applications are processed by DHS of the state, not by IM agencies. More information about the Wisconsin Well Woman Medicaid can be found at the link shown on the slide. Senior Care is a limited benefit Medicaid program and provides prescription drug assistance for individuals who are age 65 and older. Applications are processed by the Department of Health Services at the state, not by IM agencies. And more information about senior care, for more information about senior care, you can follow the link on this slide. And that is going to bring us to our last poll question before we move to some other questions. Which of the following programs is not a full benefit Medicaid program? SSI related EBD Medicaid, B, Medicaid Purchase Plan or MAP, C, Medicare Savings Programs or MSP, or D, Well Woman Medicaid. Which of the programs is not a full benefit Medicaid program? Oh, it doesn't look like the polling question is being launched. I'm not sure.
It looks like Zoom is having a few issues on the back end, and that includes launching the polling questions.
Okay,
So we're doing what we can on the back end.
got it. All right, well, let's move on to some of the questions then. And it looks like I've got questions in a couple of places here, so sorry, give me just a second.
It might be helpful, Adam, if you can call them out.
Because it looks like, I think there was something in our chat as well.
I can still see the Q&A. There was an earlier one in the chat that did come up, and it was if you have a childless adult immigrant who is blind but less than age 64, would they qualify for emergency services?
Childless adult who is blind and
I think, if I could just add, Nikki, I think it's important to remember that emergency services excludes all routine care. So when an individual is experiencing an emergency, their health needs to be attended to at that point in time. But keep in mind, planned procedures, routine care aren't within the definition of emergency services. So that might be helpful for folks to bear in mind. I understand that they would like to have coverage for something that needs to be attended to, but the way that the policy is written, it is very strict when it comes to coverage. I hope that's helpful.
yeah, and just to answer the question about blindness, if they've been determined blind by the Disability Determination Bureau and then they have that official determination of blindness, then they could potentially qualify for that. Yes. So I think that answers that question. I think that was the only one there. So can I go back to the Katie Beckett screen? Sure. That's for children with disabilities who are living at home and require an institutional level of care. Applications are processed by DHS, not by the IM agency, and the link is shown there. The next question is, can you have commercial insurance along with this? Along with which? Sorry.
Timing wise, that looks like it was about Well Woman Medicaid.
I don't know that we're going to probably have to look that one up in the handbook. I don't think there are any restrictions about having commercial insurance, but I'm not sure because it's not done by IM workers. It's done at the state, or it's done at the, not the state, but by county agencies.
Yes.
So I
We'll
don't
take that
think
back.
there's, yeah. Is there an income limit for WWWMA? Again, we'll have to take that back. That's not processed by IM agencies. So we'll have to take that one back as well. All labor and delivery services are emergency services and covered under emergency services for eligible non-qualifying aid aliens. Okay, and that was a statement, not a question. Emergency services paperwork, do the hospital give them this information to apply for ES? They may, they can, it's not required. So, and then these might be seen as routine, I'm not sure what that one was about, sorry.
I think that was just in reference to some of the emergency services.
Oh, sure.
Yeah.
Yeah.
Okay.
So it looks like we can't launch the question 5 polling question. We're
Okay.
trying, but we're getting error messages. It also seems like we're having a few other technical difficulties where if people lost their connection and tried to get back into the session, they've been unable to do so. So we're working to address those. Yes, we will note that for people who are having this technical difficulty, like we will take care of the crediting. It will be okay. And there I just got my failed to launch polling error again. But let's read through the polling question and everybody can just take a minute and think their answer, and then we'll share the answer with the group.
Yeah, sounds good. I just want to note we are at 10:17 too, so we'll finish this up and then we just have a couple more slides. So, which of the following programs is not a full benefit Medicaid program? SSI related, EBD Medicaid, Medicaid Purchase Plan or MAP, Medicare Savings Programs or MSP, or Well Woman Medicaid. And the correct answer to that is C. Medicare savings programs are not full benefit Medicaid programs. MSPs help individuals who are enrolled in Medicare pay their Medicare premiums, and in some cases, deductibles, co-pays, and or co-insurance. So I just want to give you some additional resources, online policy resources such as policy manuals, handbooks, forms, directories can be found at the first link on this slide. And the specific link for the Medicaid eligibility handbook is also shown here on the second link on this slide. And that actually does complete our presentation. We did have a couple questions that we are going to take back and answer for you. We'll get those answers back to Shannon and we will work on getting those. But if you have any new questions after this, you can go ahead and send those into the DHS Forward Health Partners inbox. And I just want to thank you all so much for your time and attention today. It's really been my pleasure to spend time with you the last couple of days. I hope you got a lot out of it, and I hope you have a great rest of your sessions.
Thanks, Nikki. It's really good to know, Nikki, just as you can tell, that's a lot of information on those EPD programs. And even I have to go back and reference the presentation just to remind myself some of those rules and limits. So don't feel bad if you didn't get everything. You will, as you do this work, eventually pick it all up.
Yeah, thanks, Adam. And thank you so much, Nikki. Thank you, Masiel. I think the other important thing to know is for many enrollment assisters, when you encounter somebody who you think might be eligible for one of these programs, please reach out to your local Aging and Disability Resource Center to connect them with a benefits specialist who can help them with an application. We wanted to share this information with you. It is good for you to have a high level understanding of what these programs are and how they function. But there is a specialist level of knowledge at your local Aging and Disability Resource Center. So know that. Now I know we're at 10:19 and everybody is eager for a break. And so we are going to take one. And we're planning to return at 10:30. I do want to preview that we are having some technical difficulties. So come back to your computer at 10:30. We will see if we have resolved our technical difficulties and we'll provide further instruction at that time. So thank you all. Thank you again, Nikki. Thank you, Masiel. Your time, your expertise is greatly appreciated. Thank you to all the attendees with your active participation. Take a 10-minute break, come back at 10:30, and hopefully we will have the presentation from the Office of the Commissioner of Insurance. Thanks all. I'm going to introduce our next session and we will go ahead and get started. But please, if anyone is still experiencing difficulties, let me know by putting a message into the Q&A. So, all right, so I want to introduce our sessions, our next session and our next session speakers. So as I said before, our next session is Health Insurance 101, and it will be presented by Shelly Knorr and Barbara Belling from Wisconsin's Office of the Commissioner of Insurance. Barbara Belling is a managed care specialist in the market analysis section of the Division of Market and Regulation Enforcement for the Office of the Commissioner of Insurance. She has over 30 years of experience working for the Office of the Commissioner of Insurance, which we often just call OCI. She is responsible for monitoring the grievance and appeal process of health plans in Wisconsin. She also serves as the division's subject matter expert for insurance coverage of mental health and substance use disorders. She has a market conduct management certification. Welcome, Barbara.
Thank you.
And Shelly is a health insurance examiner for the Office of the Commissioner of Insurance. She has been with OCI for 4 years, but in the insurance industry for over 30 years. Prior to coming to OCI, Shelly was a property and casualty underwriter. So welcome, Barbara and Shelly. I see both your faces, which is tremendous. And I am going to begin presenting and sharing my screen. So just give me a second. To get that up. No. Oh, come on, slide that. Sorry. I'm in a weird view. And I want to get into presenter mode. There we go. Here we go. Can everyone see it?
Yep.
Looks good.
And first, I just want to make sure I'm going to use Shelly, the speaker on Shelly's laptop, if that works. So can everyone hear me?
Loud and clear.
Great. Okay, and our first session is Introduction to Insurance and to the Insurance Commissioner's Office. Next slide. Our mission statement is to protect and educate Wisconsin consumers by maintaining and promoting a strong insurance industry. And this mission statement explains what we consider important as far as our mission is, and that's protecting and educating consumers. And we do that by ensuring that the insurance industry is strong. So this gives us the framework for our decisions. Next slide. OCI was created in 1870, so we've been a Wisconsin agency for a long time. And the intent is to make sure that the insurance industry meets the needs of Wisconsin citizens. And we do this through a variety of tasks. We issue licenses to insurance companies, agents, navigators, and to other entities. We monitor the financial solvency of companies and other licensees. We conduct examinations of insurers, both monitoring their financial solvency and their market practices. We assist consumers in resolving any complaints they may have about insurance and also answer their questions. We review insurance policies. Insurance policies are required to meet certain requirements under insurance law, and those policies are reviewed to ensure that they contain all of the information they're required to. We research special insurance issues. We look for trends that of problems companies might be having or other issues. We create public information about and consumer education pieces. There are a lot of brochures, fact sheets on our website that are created for consumers to give them more information about insurance. We also provide technical assistance to the legislature. And finally, we operate a state life insurance fund where Wisconsin citizens can purchase small life insurance policies. And we have a patient's compensation fund to provide some insurance for healthcare providers for medical malpractice. Next slide. Okay, this slide gives some information on from 2021. Over 2,000 insurance companies are licensed in Wisconsin for all types of insurance, whether it's auto insurance, homeowners, other commercial insurance, and of course, life and health insurance. Of those 2,000 insurers included 329 domestic insurers. And what that means is that the insurance company was created and licensed under Wisconsin law. And we also had over 197,000 insurance agents. And this shows that insurance, we have a lot of people employed and working in insurance. In Wisconsin, it's very important to Wisconsin's economy. Last year, there were over 20,000 inquiries handled by our office. And Shelly's one of the examiners who reviews those inquiries. And of those, it included over 2,500 written complaints. And we help consumers recover over $6.8 million in our complaint process. Next slide. So what is the responsibility of the insurance commissioner? As I said, and as our mission statement shows, it's to protect and educate the public and to do it in a responsible and even-handed manner. Our general responsibility is administering and enforcing Wisconsin insurance laws. It's still on the prior slide, thanks. And to act promptly in any matter that comes to our attention. And we are required to examine all of our domestic insurers. Okay, next slide. Okay, as I said, our primary responsibility is enforcing insurance laws and regulations. We're what's referred to as a regulatory agency, which means we regulate insurance we're not advocates. And we work to treat all consumers and in an even-handed manner so that they all receive the same rights. We have the power to issue orders. If we determine that an insurance company, an agent, a navigator is not complying with the law, the commissioner can order them to comply. We can require, there's a statute that requires all licensees to respond to any inquiry to our office and to provide any reports that are in a reasonable form and a reasonable interval as it's determined. And as again, we have the power to examine any licensee. We can do that through inquiry where we contact in writing and ask for information, or we have the power to do an on-site examination of a licensee. And we also have the power to rehabilitate and liquidate insurers if they do have financial problems and have bankruptcy. And there is insurance security fund that was established that provides protection if insurance company has to be liquidated. That provides some protections to people who had coverage with that company at that time. Next slide. Okay, this just gives some basic information of the areas that we, the statutes and our administrative rules explain what our specific requirements are. It outlines the commissioner's responsibilities, requirements for licensing, the requirements for financial solvency, marketing, and marketing includes marketing. It includes all policyholder services and the requirements for insurance policies, insurance contracts. Next slide. Okay, this statute lays out what the purpose of all insurance statutes is. And basically the three areas that we work towards is to balance the solvency of insurance companies, the fair and equitable treatment of consumers, and provide legislative direction and oversight. Financial solvency is important because you want to make sure that the company's there and can pay your claims when you, if you do have a claim. Policyholders, claimants, and insurers all have to be treated on an equal basis. And freedom to contract, freedom of enterprise, both for insurance companies and for consumers. So there is a level playing field. And next slide. As I said, if we do determine that there is a problem with an individual or organization that is not complying with our requirements, the commissioner can issue an order to comply. We are required to hold a hearing before we issue any administrative regulation or formal guidance. And agents, navigators would have the right to request a hearing if we take any action, enforcement action against them generally before we take action. So in addition to ordering them to come into compliance, we can also require forfeiture, which is basically a fine and if there was harm to consumer, we can order restitution to the consumers. In addition, we can other sanctions, could include suspending a license or completely revoking a license. Generally, there are some exceptions to holding a hearing. If the commissioner determines that there could be consumer harm, if the license is not suspended or revoked, they can order that before a hearing. Also, if a navigator or agent fails to comply with any submitting any required fees to our office or complete continuing education requirements, the license may be revoked without a hearing. And we're required to revoke a license if the navigator is liable for delinquent taxes. Next slide. Insurance companies are licensed by our Division of Financial Regulation, which is also responsible for monitoring the financial solvency of insurance companies. The agent licensing section in the Division of Market Regulation licenses insurance agents, navigators, insurance agencies, some administrators, and other entities. The Division of Market Regulation is also responsible for regulating insurance marketing practices, which includes both the marketing, advertising, selling of insurance, policyholder service, claims administration, and other practices like that. We regulate, Division of Market Regulation regulates navigator and non-navigator assisters. Next slide. When is a license required? Basically, a license is required whenever, for any individual or entity that is doing the business of insurance. A person, an entity may not solicit, negotiate, sell, or advertise any service unless the person obtains a license first. They may not use, individuals should not use the services of an intermediary if that person knows the person does not have a license. However, a licensed insurance contract is valid if it was sold or serviced by an unlicensed intermediary. And that again is to protect the consumer. Next slide. So I'll just let you think about these. Is a license required in each of these three situations? A person who incidentally advises other persons about insurance needs and coverages during the normal course of his or her non-insurance related business, and who receives no direct or indirect compensation on account of any transaction which results from the advice. So just think about that for a moment. Would that person need to be licensed? Is that person doing the business of insurance? And the answer is no. This person would be, this situation is an exception. This person does not need to be licensed because they are not doing the business of insurance, and it's just an incidental part of their business. How about a person who places insurance for an insurance company on a door-to-door basis? That person does need to be licensed. They are marketing insurance. They need to be required to have a agent license. And in addition, if they're marketing on a door-to-door basis, they are required to indicate at the beginning of the conversation, any conversation with someone, that they are an agent and that the purpose of their call is to market insurance. How about a person who advises other persons about insurance needs and coverages and is directly compensated by an insurance company or the insured? And again, yes, that person is doing business of insurance and needs a license. Next slide. So what is insurance? Risk, as far as insurance goes, risk is the uncertainty of a financial loss. Different individuals have different concepts of, or different tolerances of how much risk they're willing to take. I have a fairly low risk tolerance. Some people who have different circumstances, different conditions, may have a very high tolerance and they be willing to keep risk, more risk for themselves. Insurance is defined as the transference of risk. An individual pays an insurance company to take risk for that, for certain services. So the consumer will purchase an insurance policy, pay the premium, the insurance company agrees to take some risk. And generally, the more risk that is taken, the higher the payment or premium will be. Pooling is basically spreading risk. Generally, with insurance, the more people who are in the same pool charge the same premium, risk is spread because not everyone uses the same amount of insurance. For example, if you have a large employer with, say, 1,000 employees, that employer spreads the risk among all of the employees. Some employees may be healthy and use very few healthcare services. Others may use a lot of healthcare services, but the risk is spread among all of them. One of the things that the Affordable Care Act did was, for individuals, was to put risk pools for those individuals and have certain requirements and limits on how much the premium could be. So there would be a large group of individuals purchasing that individual insurance policy and spreading the risk among them. An insurance policy is a contract. It's a legal contract, and the elements of a contract are: one party makes an offer, the other party accepts the offer, and there's some consideration or money exchanged, and with the intent of creating a legal relationship. With health insurance, the insurance company makes an offer to provide coverage of whatever the benefits in the policy, provide certain circumstances. The individual applies for that policy, pays the initial premium, and that the policy is issued, and that's a legal contract. And once the policy is issued, it is enforceable under contract law and insurance law. Health insurance contracts have some unique aspects to them. Most, if not all, health insurance in Wisconsin is some type of network plan or managed care plan. And that could provide different benefits depending on whether the services are provided by a provider that's within the insurance company's network. Some examples would be preferred provider plans or health maintenance organizations. Some of those plans may allow someone to receive some benefits if they go to a non-network provider. Some will not provide coverage. We'll talk more about that later. Other thing is a maximum out of pocket. All individual health insurance has a maximum out of pocket. And what that means is that it's the maximum amount of money in a year that an insured consumer is required to pay for certain services. And it generally applies to deductibles and other cost sharing. It wouldn't apply to the premium, and it generally only applies to services that are covered services from network providers. Types of cost sharing that consumers are required to cover could be a deductible, which is the annual amount that the consumer has to pay for covered services before the insurance company starts providing their coverage. A co-payment is a fixed dollar amount that's generally has to be paid each time someone receives those services. For example, it could be a $30 co-payment every time that they have an office visit with their doctor. And coinsurance is generally a percentage of the claim that has to be paid by the consumer. Health insurance contract will also spell out the terms of coverage, what is covered by the policy and what is not covered, or the exclusions and limitations. I don't know of any health insurance policy or any other type of health plan that covers all medical services. All policies have exclusions and limitations. They may have a limitation requiring prior authorization for certain services or other services. So I've always suggested that people look at the exclusions in the policy, any policy that they're considering purchasing, just so they understand what will not be covered. Next slide. Wisconsin's insurance laws apply to policies sold in Wisconsin. So they don't apply to someone if someone purchases a policy in another state and moves to Wisconsin, that other states' laws would generally apply. So in most cases, it's policies sold in Wisconsin. Policies do need to comply with readability requirements. It's one of the things that we would look at if we're reviewing an insurance policy. Now, the readability is intended to help consumers be able to read and understand their policy. I will say that the minimum score for most health insurance policies is 40 under the Flesch Reading Ease test. And that is a test that makes a determination based on the number of words in a paragraph, number of syllables, and a minimum score of 40 is a fairly tough read. I think it's about 11th or 12th grade reading level. So again, these are insurance contracts. The terms that are used may be used differently in an insurance policy than what a consumer may think. But they should be defined. It should be clear. Insurance agents are agents of the insurance company. They represent the insurance company. And so a notice that a consumer makes to an agent, well, if they're purchasing a policy, is considered notice to the insurer. And the insurer is bound by the acts of the agent within the scope of that agent's apparent authority. representations are statements, it could be statements by the agent or statements by the app regarding what is covered in the policy, or they may be oral or written statements by the applicant. Statements by, again, statements, oral or written statements by the applicant to an agent is considered the same as notice to the insurance company. Privacy protections. This is very important. As a navigator or a certified application counselor working with consumers, you may be receiving information or have access to consumers' personal medical information or their financial information. This is considered private information. Wisconsin insurance law requires that processes be put in place to keep that information private and not make it, release it to, so anyone can see that. It's also, there are also federal laws, the Health Insurance Portability and Accountability Act, which is known as HIPAA, has privacy protections in, as the Grain-Leach-Bliley Act. So there's federal laws, there's state laws. I believe there the Affordable Care Act has specific privacy requirements for navigators and CACs, and that you will learn more about when you take the federal training. And finally, anyone has the right to file a complaint with our office. And we will review any complaint to determine whether there's what we can do to assist that person. Next slide. Okay, a polling question. An insurance company is bound by the acts of its appointed agent when the agent acts within the scope of their apparent authority, even if they do not have actual authority from the insurance company.
Looks like about 2/3 of participants have done the poll. We'll just give it another minute.
True. Okay, 78% said true. And it is true. As an appointed insurance agent represents the insurance company, and the insurance company is bound by their acts within the scope of their apparent authority, even if they don't have actual authority. It's the insurance company's responsibility to make sure that their agents are acting appropriately. Again, that is one of the consumer protections. Okay, and I will let Shelly take over.
Good morning, everybody. So we'll we'll continue, I should say, with some of the slides on insurance contracts. Regarding the notice of a claim, proof of loss is to be furnished to the insurer as soon as reasonably possible and within 1 year after the time it was required by the policy. An example of this would be submitting a prescription cost receipt in a timely manner for something you had to pick up while on vacation once you return home. Unless otherwise provided by Wisconsin law, prompt settlements of claims is subject to interest payments. An insurer must promptly pay most insurance claims within 30 days after receiving. As for a legal mistake, what is the legal effect of a mistake in an insurance contract? In most circumstances, unless otherwise provided, general contract law applies to mistakes in insurance contracts. For example, in property insurance, a mistake is designating the person to whom the insurance is payable, and it does not void the policy. Such a mistake does not constitute a defense for the insurance company unless the mistake was due to misrepresentation or concealment by the owner of the property. Next slide, please. What are some examples of unfair claim settlement methods and practices? 1, the failure to promptly acknowledge pertinent communications with respect to claims arising under insurance policies. 2, the failure to promptly provide the necessary claim forms, instructions, and reasonable assistance to insureds and claimants. 3, the failure to attempt in good faith to effectuate fair and equitable settlements of claims in which liability has become reasonably clear. And 4, knowingly misrepresenting to claimants pertinent facts or policy provisions. Each line of insurance has a period of time for which a consumer can return the policy without any penalty. Life insurance, for example, is 30 days after the delivery for a full refund when a new policy is sold in a replacement of an existing one. For health insurance, a policyholder may return any individual health policy within 10 days after receiving it. If the policyholder returns that policy within the 10-day period, the insurance contract is invalid and all payments made under the contract must be refunded. The right to return must be printed on or attached to the first page of an individual policy. For grace periods, although an insurer may cancel a policy for non-payment of premiums, a consumer is entitled to a grace period for the payment of any premium due. During this grace period, coverage does continue. Per state law, per state law for health insurance policies, it is not less than 7 days for a weekly premium policy, not less than 10 days for a monthly premium policy, and not less than 31 days for all other policies. A consumer should always check their policy to see if their insurer includes a grace period provision. ACA plans will have different grace periods depending on whether they are receiving the advanced premium tax credit or not. Next slide, please. Here are some examples of plans that OCI does not regulate. Self-funded ERISA plans are typically large employers that are not governed, that are governed primarily by the U.S. Department of Labor when a state's law or regulation is related to the business of insurance. That state may retain jurisdiction over that piece of the plan. There are a few self-insured employer plans that fall outside the federal jurisdiction, such as self-insured non-federal government plans and church plans. Labor union and employee welfare plans are also governed by the U.S. Department of Labor. Discount plans provide discounts on medical procedures for certain doctors or medical related costs, such as prescriptions, just like using a coupon at the store. These plans are not health insurance plans in the traditional sense. excuse me one second here. Medicare Advantage plans are the federal government's version of a Medicare HMO. The Centers for Medicare and Medicaid Services, also known as CMS, directly contract with insurers to provide the Medicare benefits. States have negotiated, though, and retained jurisdiction over the agents as they are our licensees. Medicare Part D is the prescription drug plan that is sold separately from Medicare supplement insurance or traditional A and B coverage by the feds. Healthcare sharing ministries were the original form of a GoFundMe account. In Wisconsin, there is an exception for members of a denomination or organization that agree to help financially support fellow members. The member is required to pay all medical bills first and then post their needs in a newsletter for other members to be able to donate funds to offset that person's expenses. And lastly, direct primary care is reemerging from the past. Typically, primary care internists or family practitioners negotiate directly with consumers. OCI does monitor these offerings as frequently there is a component of risk transfer. Next slide, please. Here are some of the key practices OCI monitors. Some examples of these are the following. Under unfair marketing practices, this can include misrepresentation, restraint of competition, and choice of insurer. For misrepresentation, that can include omissions, misleading facts, and false entries. For restraint of competition, that can include a boycott of an insurer and intimidation. Choice of insurer can include requiring purchase of insurance as a condition of a contract not related to insurance. And home solicitation and sales can include clear statements on the intent to sell insurance as part of the visit. Next slide, please. Prospective buyers of disability insurance must be provided with clear and unmistakable statements, explanations, advertisements, and written proposals concerning policies offered to them. This includes printed and published material, including the internet and web pages, social media pages, including social networking websites, descriptive literature, and sales aids of all kinds issued by an insurer or agent for presentation to members of the public, and prepared sales talks, presentations of materials used by intermediaries and representatives made by the agents in accordance with these talks and exhibits. Advertisements and representations must be truthful, not misleading, and must accurately describe the policy to which they are applying for. Please note that an advertisement means printed as well as oral representations. Advertisements may not directly or indirectly make unfair or incomplete comparisons of policies or benefits. And lastly, advertisements may not falsely or unfairly disparage, discredit, or criticize competitors, their policies, services, or business practices. Next slide, please. And we've come to our next polling question. Which of the following are not considered insurance? Health sharing ministries, self-funded ERISA plans, Medicare Advantage plans, or D, all of the above?
think about 3/4 of people have submitted answers. We're just going to give another 30 seconds.
And it looks like we have a majority that says D, all of the above, and that is the correct answer. The 3 previous that are listed above there are not considered insurance, and therefore OCI would not have regulation over them. Next slide, please. Here are some of the common federal laws that can impact health insurance. Medicare is a broad program of health insurance designed to assist the nation's elderly to meet hospital, medical, and other health costs. Medicare is available to most individuals 65 years of age or older. The Employee Retirement Income Security Act of 1974, also known as ERISA, is a federal law that sets minimum standards for most voluntarily established retirement and health plans in private industry to provide protections for those individuals in these plans. COBRA gives workers and their families who lose their health benefits the right to choose to continue that group health coverage provided by the group health plan for a limited period under certain circumstances such as voluntary or involuntary job loss, reductions in the hours worked, transition between jobs, and other life events. Qualified individuals would be required to pay the entire premium for coverage. The Mother's Health Protection Act includes important protections for mothers and their newborn children regarding the length of the hospital stay following childbirth. This requires group plans that offer maternity coverage to pay for at least 48 hours of hospital stay following childbirth or 96 hours in case of a C-section. The Women's Health and Cancer Rights Act of 1998 is a federal law that provides protections to patients who choose to have breast reconstruction in connection with a mastectomy. This law applies generally both to persons covered under group health plans and persons with individual health insurance coverage. As Barb previously mentioned, HIPAA was developed in 1996 and became part of the Social Security Act. It set national standards to protect individuals' medical records and other personal health information. It gives patients more control over their health information, and it sets boundaries on the use and release of health records. MAPIA prohibits health plans that offer mental health benefits from imposing more restrictive annual or lifetime limits on spending for mental illnesses that are imposed on coverage of physical illnesses. The Affordable Care Act, or ACA, ensures that all Americans have access to quality health insurance that is affordable. It eliminated the pre-existing clause that prohibited some consumers from being able to purchase a quality health plan. And lastly, the Federal No Surprises Act was effective for services received after January 1st, 2022. This protects a consumer from surprise bills for emergency services received from an out-of-network provider or facility and without prior authorization. Out-of-network cost sharing, like out-of-network coinsurance or copayments, for all emergency and some emergency services. It also protects consumers of out-of-network charges and balance bills for supplemental care, like radiology or anesthesiology, by an out-of-network provider that performs that service in an in-network facility. Next slide, please. Medicare is the federally funded and regulated program under the U.S. Department of Health and Human Services. It is available to most individuals 65 and older. It also includes folks that may have the end-stage renal disease. Excuse me. Although folks may qualify under the end-stage renal disease, they're eligible for Medicare, but there is also a state mandate for the coverage of kidney disease. Wisconsin is an exempt state from the Medicare supplement products, which I will explain further in the next slide. Wisconsin is a waived state, which means we provide a different kind of Medicare supplement policy not labeled with letters. Medicare supplement policies in Wisconsin have set minimum comprehensive requirements for supplemental coverage. Individuals have 6 to 7 rider options that are available and must be separately priced from the base coverage. Some examples of these riders are foreign travel, Medicare excess coverage, and inpatient deductible coverage. If a consumer comes to you stating that they are being quoted a supplemental plan with a letter name, advise them to make sure this is a Wisconsin plan being quoted and not one based in another state. Insurance companies sell policies referred to as Medicare supplement policies to fill gaps left by Medicare. Medicare was never intended to pay 100% of a person's medical bills, but it was created to offset medical expenses by providing basic foundations of benefits. Medicare requires a person to pay deductibles, and many Part B expenses are paid then at 80% of the Medicare approved amount. Next slide, please. Insurance companies have the right to ask for additional information or documentation to help adjudicate a claim. A consumer may need to become involved with the process of assisting in obtaining this information from their provider if there seems to be a disconnect between the company and that provider. We will see complaints where a company may say they never got this information, and a consumer says, yes, it was sent. But again, it may come down to the consumer just getting more involved to be able to help, get the claim paid. Next slide, please. The non-renewal notice reasons given when non-renewing a policy must be clear and concise to the consumer, and they cannot use general terms. Reasons that are not acceptable under this definition would be condition of property, damage to vehicle, coverage not offered. They must be specific in their terminology. So for example, on the property and casualty side, when I used to non-renew a homeowner's policy, if it was due to an inspection, you would list all the conditions or issues that you found on an inspection. The roof is curling, you may see damaged siding. You need to list those specifically on a non-renewal notice. Next slide, please. This slide pertains specifically to midterm cancellations. Nothing is official until a consumer has been given a 10-day notice. This notice could be provided by email, assuming that there is language in the policy informing an insured of this ahead of time, and that the insured has agreed to this method being used. The Court of Appeals in Wisconsin has ruled that when using the Postal Service to mail a cancellation notice, the written notice to the policyholder refers not to the receipt by the policyholder, but to the date the notice was mailed by first-class mail, as permitted by statute. Next slide, please. As a health insurance examiner, these are some of the questions that I ask myself when reviewing a company or agent response to a complaint. At OCI, we want the problem resolved within the guidelines of insurance laws and statutes, and do not want to see a problem continue in addition to making sure a consumer was not harmed or wronged in any situation. Next slide, please. The Consumer Affairs team at OCI is dedicated to protecting and educating Wisconsin insurance consumers. A complaint must be filed in writing to allow for their side of a story to be presented to the insurance company, agent, PBM, or medical provider. Wisconsin Open Records Law was enacted in 1982 and is a series of laws designed to guarantee that the public has access to the public records of government bodies at all levels. When you file a complaint, that becomes an open record, and once the complaint is closed, generally a person may make an open records request, but there are some restrictions. We make all efforts possible to protect a person's private, financial, and health information. There are electronic forms available on our website to submit directly to our office. Next slide, please. On our website, we also try to educate consumers prior to submitting a complaint on what they can expect from our agency. The company, agent, PBM, or provider response should provide us with a clear and detailed picture of the events surrounding the complaint and what, if any, resolution can be provided to assist with the situation. We try to educate consumers on how their insurance policies work, that we have also been providing publications and links to other documents and websites as well. If it's a matter that we don't have jurisdiction over, we will refer the consumer to the best organization available to handle it. Next slide, please. We also try to educate consumers upfront on situations that we cannot handle for them and to look at consulting with an attorney about their specific rights. As a health insurance examiner, the main issue that we run into a lot is being asked to make a medical determination. We are not healthcare professionals and we cannot read medical charts or doctor's notes to make any assessments. Medical necessity is a term defined in an insurance contract itself, and Wisconsin law does not define medical necessity or mandate the criteria that an insurer must use to determine it. Each insurer establishes its own criteria for determining if a particular service or treatment is medically necessary. We also cannot assist in determining what a consumer feels is the right amount of money to make them whole again. We will see complaints come in that says, I've spent hours on the phone trying to get the insurance company to pay that, and I want to be compensated for it. That's something that, again, insurance law statute does not address, and that would need to be handled through the court system. There are times, again, when we don't have jurisdiction in a matter such as self-funded plans. We will refer a complainant to the proper entity for review and assistance. Last slide, please. So we have come to the end of this presentation. Shannon or Adam, are there any questions that Barb and I can help with?
No questions in the Q&A, but we can give people a couple minutes if they want to, think of their questions or, just give them a chance to kind of process everything.
Okay.
Thank you.
You bet.
Yeah, attendees, please take your time to enter any questions you have. Shelly and Barbara, did you want to get started on the content for tomorrow? We have 30 minutes remaining, and I know it can be hard to get through both tomorrow's slide decks and the amount of time we have.
Yeah, we can definitely do that. Just if you can give us a moment to kind of pull up our PowerPoints and our ends with our notes, we'll be ready to rock and roll.
Great. Yes, I'll need a moment to switch over PowerPoints as well. So
okay, sounds good.
So everyone, if you have a question, go ahead and enter it. I also want to point out that in the chat, Adam put a helpful study guide from the Office of the Commissioner of Insurance that reviews the concepts and has great written detail about much of what was covered today and more. So what will be covered in the next slide deck and the next presentation rather, and the presentations tomorrow. So please check out that study guide. We will talk about it a little bit more tomorrow as well. So I'm going to go ahead and switch over decks, and then we'll be back to wrap up the last 30 minutes of today.
Yep. And I don't know if we'll get to them or not, but polling questions have to be entered separately, so we'll have to get to those tomorrow for the extra content.
Adam, Mike built in 2 polling questions from tomorrow's slide deck into today because we anticipated this might happen, so they should be there.
Yep, I see him. Great. Awesome. Thank you.
Shannon, do you want us to kind of like do a hard stop at 5 to 12 in case there's any questions? What are your thoughts?
Yeah, let's do that. So let's, we'll just jot down how far we make it through
Okay.
this next bit of content, and then we'll pick up on that same slide tomorrow morning.
Okay, sounds great. Just want to make sure we're on the same page.
Right. Thanks, Shelly. Thanks, Barbara.
Okay, are we ready to go? Next slide. Again, this is our mission statement, and it emphasizes that our mission is protecting and educating Wisconsin consumers. And we do that through promoting a strong insurance industry. Next slide. In health insurance began in approximately 1929 when large industrial employers wanted to provide some additional benefits for their employees, and they created some access to health insurance. So in the previous deck, we talked about our office started in 1870. And so we worked with other types with the properties, casualty, life insurance. Health insurance was relatively new. Then between 1950s and 60s, labor unions began trying to get more benefits for their employees, their union members, asking for health insurance to provide coverage for catastrophic health conditions. And at that time, it was covered more major health claims, hospitalizations, other claims. Medicare began in 1965. Shelly just talked a little bit about what is covered in Medicare. Began with Medicare Parts A and B. And then beginning in the 1970s, managed care became more prevalent with HMOs, health maintenance organizations. At this time, most, if not all, health insurance in Wisconsin is some type of managed care plan. And all of the coverage that's offered on the federal exchange is managed care plans. Next slide. Okay, and we just talked about this a little. I'll go through it again, just quickly. Risk is the uncertainty of a financial loss, and different individuals are willing to keep that risk for themselves. Other people want most of the insurance company to cover most of that risk, and that's risk tolerance. Insurance is transference of risk. Pooling concept, again, that is spreading the risk among all individuals within a group. A large employer who has many younger employees, healthy employees, also some older employees. When they spread that risk among all of those employees, they may have be able to lower the premium and the costs. With individual coverage, where you don't have that large group of employees, the Affordable Care Act addressed that by limiting the premium amount and encouraging everyone to have insurance so that spread the risk among everyone. Yes. Disability insurance. It's defined as insurance that covers policy claims involving medical and surgical expenses, indemnities for loss of income due to accident or health, accidental death and disability coverage, hospital care, and long-term coverage. When I started working at OCI, if someone had mentioned disability insurance, I thought it was number 2, indemnity, which is disability income insurance. But in Wisconsin, disability insurance covers all types of health insurance. And next slide. Okay, as we've talked about before, generally, insurance is regulated by the state in which the policy is purchased. So Wisconsin OCI regulates insurance sold in Wisconsin, with the exception that for group or blanket policies covering risks that where at least 25% of the insured individuals or certificate holders reside in Wisconsin. So in that may be a case where an employer is located, say, in Northern Illinois. They purchase a policy in Illinois, but 25% of their employees reside in Wisconsin. Wisconsin law would have jurisdiction for those Wisconsin residents. The types of health insurance, a group insurance policy is any policy that provides coverage for an employer on behalf of at least 2 employees, eligible employees, and it could also include individual health insurance in some cases where 3 or more eligible employees purchase a policy through that employer. A group health plan is the ERISA definition. And again, ERISA is the federal law that governs employer group health plans and other benefits that employers offer. A group health plan would include all group insurance policies and also would include the self-funded health plans that employers offer. Our office would regulate the group insurance plans. The self-funded plans are solely regulated by the Department of Labor. A managed care plan or a defined network plan is a plan that requires an enrollee to or creates incentives for an enrollee to use providers that are within the network of the insurance company. Next slide. Some other terms you may hear: healthcare plan is any plan that covers any type of healthcare expenses. It's a very general term. Comprehensive health insurance policy covers a wide range of services, covers outpatient services, outpatient office visits, other outpatient services, hospitalizations, inpatient treatments, and generally covers some prescription drugs. All plans that are marketed on the federal exchange are comprehensive health insurance policies. Disease specific or duration specific coverage is an alternative to coverage, and they provide coverage for specific benefits or for a specific time frame. Next slide. Okay, as we talked about with pooling, the larger the group that's pooled together, the greater ability to spread the risk. With large employers, their employee group is often large enough to spread the risk among people who don't need to use a lot of health care and others who do. With the individual policies, the ACA pools people together to spread that risk. As different types of plans, product options, traditional health 80-20 plans. You do not see this much in Wisconsin, and they're basically plans with insurance policies. They're generally plans where the consumer can see any provider they want, and they pay, the insurance company pays, in this case, 80% of the plan of the claim, and the consumer pays 20%. Managed care plans are a type of health insurance. They have contracts with healthcare providers and medical facilities to provide care for members at reduced costs. Generally, in those providers who have contracts with the managed care plan make up the plan's network, and generally, depending on the type of plan, the consumer who is insured by that plan either is required to use that network provider or receives a better benefit if they do see that provider. For example, health maintenance organizations, HMOs, usually will only provide coverage for care that's received within the network. Federal state programs. Medicare is a federal program. Medicaid, Badger Care are federal state programs. They're not health insurance. Our office doesn't regulate them. Next slide. Managed care plans. A managed care plan is defined as any health benefit plan that requires or creates incentives for an enrollee to use providers that are owned, managed, or under contract with the insurer offering the health benefit plan. Wisconsin insurance law defines 3 different types of managed care plans. They are health maintenance organizations, preferred provider plans, and limited service health organizations. A defined network plan or a managed care plan requires or creates incentives for the enrollee to use providers that are managed, owned, or under contract with the insurance company. And basically, the more providers that can be used, or the larger the network, the higher the premium is going to be. Next slide. There's, as I indicated, there's a trade in choice of healthcare providers, the number of healthcare providers that may be available to the network with premium. The more choices an individual wants or may need, the higher the premium is likely to be. The reverse is also true. If your consumer is willing to significantly restrict their access to a single group of providers, there's often a lower premium. The type of plan with the least number of choices is an exclusive provider organization, or an EPO. You may also hear it referred to as a skinny network plan, or a narrow network plan. And they generally have very limited group of providers. They're still required to have network providers that can provide all covered services, but there may not be much choice in the providers. And they generally will not provide coverage for services that are received from non-network providers. The greatest number of choices might be a point of service plan, also a preferred provider plan. Those types of plans often will may provide a greater choice of network providers and provide some limited coverage of services from non-network providers. Next slide. These are some of the different types of managed care plans. A health maintenance organization is a managed care plan that makes available to enrolled participants comprehensive healthcare services performed by providers selected by the organization. Generally, within HMO, services must be provided by network providers in order to receive coverage. A limited service health organization is similar to a HMO, except that it provides only a limited types of services. For example, it may only provide dental services or vision services. A preferred provider plan or preferred provider organization plan is a managed care plan that provides a specific level of benefits if plan providers are used, and a lesser amount if non-plan providers are used. It offers obviously financial incentives to use network providers, but it's more flexible than an HMO in that it does provide some limited amount of coverage if someone uses a non-network provider. A point of service plan is somewhat like a preferred provider plan. It may require referrals from a primary care provider, but it will also provide some services generally for out-of-network providers. Next slide. This is just a graph to show it's not in any type of the services. It's not intended to be exact, but just to give you an idea that the more choice in the number of providers, which is the blue line, the higher the premium is going to be, which is the red line. However, one thing I do want to make sure you understand is that the premium should not be the only reason that someone chooses a healthcare plan. It's obviously very important, but the choice of providers is also important, especially for a family where the different family members may have different needs. So understanding what the limitations are and what an individual or a family's needs are is also important. Next slide. Accepted health policies or accepted benefits. These are types of plans the term accepted means that they are not subject to most healthcare, to most of the requirements under the Affordable Care Act. They're accepted from the Affordable Care Act. They generally provide a narrow amount of coverage in certain circumstances. And I won't read them. It's just as an example, a cancer-only policy may provide coverage to someone who receives a cancer diagnosis and for certain services if they receive a cancer diagnosis. Hospital indemnity policy may provide a specific amount of money for someone who is an inpatient in a hospital. In some cases, it may not require any specific, that the benefit be tied to specific claims. It may say that if you're an inpatient in the hospital, they'll pay $50 a day or $100 a day to help the consumer. But they generally very narrow and not amount of money. Next slide. Qualified health insurance or qualified health plans is comprehensive policy. These are the plans that are offered on and off the exchange to individuals and to small groups. All plans offered on the exchange are qualified health plans. Medicare supplement plans provide some costs that are not covered by Parts A and Part B of Medicare, as Shelly explained earlier. Medicare Select plans are a type of Medicare supplement plan that's generally offered by a managed care company and generally has network providers that must be used in order to receive the supplemental benefit. Long-term care, it refers to a broad range of services that someone may need for an extended period of time because of chronic illness or a disability. It could include medical services. It also could provide supportive care for activities of daily living, such as bathing, dressing, help getting in and out of bed, or preparing meals. Care can be provided, and long-term care policies may cover a wide range of services in settings such as nursing homes, daycare centers, or provide care at somebody's home. Short-term limited duration plans, we may just have time for that one. Next slide, I'll talk about those. Short-term limited duration plans were originally designed to help people who were between health plans. For example, for someone who is changing from one job to another and wouldn't have insurance for 3 months, could purchase a short-term policy for that to cover them for that period. However, short-term limited duration plans typically do exclude coverage for any pre-existing condition, and they do look at someone's health coverage when paying a claim, and they could deny a claim if they determine that there were prior symptoms that the person had that may have caused that person to have seek coverage before the policy was in effect. Short-term plans cannot be used for ACA subsidies or other subsidies, and there is no guarantee with those plans that they can be renewed. And often if someone renews the policy or thinks they're renewing the policy, they're being issued a new policy, and any pre-existing condition limitation would start over. right, do we want to go on or?
Shannon, is this a good break point?
This is probably fine. I cannot go ahead since I'm in presenter mode. How close are we to the first polling question for this slide deck?
We're on slide 15 and that doesn't come into play till 24.
All right, well then I think we can pause here. We will return tomorrow morning. And we will start in on this slide, Healthcare Sharing Ministries. Thank you both, Barbara and Shelly, for presenting today. We appreciate it. If you have questions, we have 5 more minutes. So go ahead and pop your question into the chat or into the Q&A. There were a few sort of technical questions, which I can review while people are maybe putting in their content questions, which is, tomorrow's presentations and information will be available no later than tomorrow morning. You'll get that welcome morning email again sent by Mike, our amazing technical support lead here at Covering Wisconsin. Thank you, Mike, for all that you do. And then it was also shared for those of you who are having trouble loading the presentations for today to download the PDFs, that eventually it seemed like clearing the cache, like things caught up. It just took a little time. So I encourage you to do that clearing and try again a bit later to download the PDFs of the presentations if you want to have those. So I am not seeing any questions come in. Adam, are you seeing anything?
Yeah, we have a couple.
Okay.
One is just clarification on whether Medicare Advantage plans are health insurance plans, like whether they're full health insurance.
No, Medicare Advantage plans are a type of Medicare.
Yep.
They are not health insurance plans. They're regulated by the federal government, and the federal government Center for Medicare and Medicaid Services, or CMS, has a contract with insurance companies to offer those plans.
Great. And then on the first page of the managed care plans, Barb, you stated 3 things that were not listed on the managed care plan. Can you please relist those 3?
That page.
Okay.
Okay. I think what I talked about was, see if we can get my notes on the right page. Sure, is it that one or that one? Was the first one? Was that basically? I think it was Wisconsin insurance law defines health maintenance organizations, or HMOs, preferred provider plans, or PPPs, and limited service health organizations. And this page that you have up now also gives a little bit more about what the definition is. The insurance law does not specifically define points of service plans, but they are a type of plan often offered by an HMO to offer a little bit wider choice of providers.
All right. Hopefully that answers that or clears some of that up. Looks like the other questions. Shannon, can you see the questions or no?
Yes, I've got them
Okay.
now.
Okay. Looks like there's some technical stuff.
So I see for comprehensive insurance, I think people wanted to see this page again. And then question about what is insurance might be better worded to say plans that are not regulated by OCI. So I think we have a comment. I'm not sure what it is attached, which question it's attached to, but I can go back within the slide deck. We're at 12 o'clock. So if we didn't address your question today, bring it back tomorrow. When we start back in, and we will make sure to address your question at that time. So thank you all for attending today. Thank you for sticking with us through some technical difficulties. Thank you, presenters, for your time. And we look forward to seeing you all again at 9 o'clock for our last 2 sessions of pre-licensing training. And again, we'll have our presenters from the Office of the Commissioner of Insurance, Barbara Belling and Shelly Knorr. Thank you.
Great.
Thanks, everybody.
Thank you.
Thank you.